Hello, my name is Rebecca Olsen, and I'm a second-year osteopathic medical student at AT Still University in Mesa, Arizona. And I also wanted to acknowledge my fellow authors at the Honor Health Dermatology Residency Program in Scottsdale, Arizona. And today I'm going to be presenting on fixed drug eruption secondary to COVID-19 vaccination. So let's get started. All right, let's start out by generally talking about vaccine hypersensitivity reactions. When we hear that phrase, most people first think of a friend or a family member that had a reaction to a vaccine. Maybe they were allergic to eggs or gelatin, which are common inactive substances added to various vaccines. So why would they add something like eggs to a vaccine? It's not like we're making a cake. Well, vaccines are composed of several ingredients besides the antigen preparation itself. Think of it like a recipe for your grandma's famous chocolate chip cookies. Every ingredient serves a purpose. So, hypothetically here, if we were to make a vaccine, we would add a dash of adjuvants to enhance the immune reaction to the vaccine, a sprinkle of stabilizers to stabilize and let the vaccine have a longer shelf life, and a pinch of preservatives to, as its name implies, preserve the vaccine. These additives, adjuvants, stabilizers, preservatives, are termed excipients. And I have to say, this is an oversimplification and not actually the true recipe to make the vaccine. That recipe would not fit on a simple note card like you see on the slide. All right, so let's return to talking about vaccine-associated hypersensitivity reactions. These reactions are often associated with excipients of the vaccine, but can on rare occasions be a reaction to the antigen itself. Hypersensitivity reactions to vaccination are fairly common. However, the more serious acute reactions, such as complement, IgE, or IgG-mediated anaphylactic, or delayed onset T-cell mediated systemic reactions are very rare. Anaphylaxis, which is a severe, potentially life-threatening allergic reaction, which could present with many different symptoms such as generalized urticaria, also known as hives, wheezing, mouth, tongue, and throat swelling, hypotension, and many others. It is estimated that the risk of anaphylaxis after all vaccines is approximately 1.31 per million vaccine doses. I want to briefly distinguish between acute onset and delayed type hypersensitivity reactions. The acute type reactions are predominantly type 1 hypersensitivity reactions affiliated with IgE antibodies against a component of the vaccine. The onset is within minutes to up to 4 hours post-vaccination, and symptoms include urticaria, which is a fancy word for hives, angioedema, which is swelling under the skin, or anaphylaxis that we previously discussed. Comparatively, the delayed type reactions are type 4 reactions mediated by T cells. The onset is within hours up to 2 to 3 weeks post-exposure, so a lot later onset, and they commonly appear as various forms of maculopapular eruptions and or a persistent hard nodule at the injection site. A maculopapular eruption is a description of a rash that is composed of both raised and flat cutaneous lesions. With the rapid rollout of mRNA and recombinant adenovirus vaccines against SARS-CoV-2, cutaneous reactions have been reported, but are not well characterized at this time. In today's presentation, I will be focusing on the clinical case of a female with a history of rheumatoid arthritis on etanercept, who had an unusual cutaneous reaction after both doses of the Pfizer-BioNTech COVID-19 vaccine. Here we present a 64-year-old female with a significant past medical history for rheumatoid arthritis since she was 10 years old and has been on etanercept 50 milligrams weekly for the past 3 months. In April of 2021, the patient received her first series of the Pfizer-BioNTech COVID-19 vaccine. Within the first 24 hours post-vaccination, she reported fatigue, headache, but no other significant symptoms. Approximately 1 week post-vaccination, she reported a pruritic rash located on her anterior neck and upper chest. This rash resolved over 2 to 3 days without treatment. The patient received her second dose of the Pfizer-BioNTech COVID vaccine in May. Within 24 hours of receiving the second dose, the pruritus returned on her anterior neck and chest, along with raised erythematous plaques. Over the next 24 hours, the patient reported that the plaques became more prominent, and she began experiencing burning as the lesions evolved into erosions. She was seen in the clinic approximately 48 hours after the onset of her symptoms, presenting with erythematous to violaceous papules, coalescing into plaques with interspersed secondary erosions distributed over the anterior chest and neck. The anterior neck displayed linear erosions in the neck fold, as shown in the images on the slide. It's important to note that the mucosal surfaces were not involved and no other areas were affected except for the upper chest and the anterior neck. All right, so then the patient was prescribed 20 milligrams of prednisone for 5 days and a topical clobetasol 0.05%. 2 punch biopsies, basic lab work, and an autoimmune panel were ordered, and the patient was scheduled to follow up in 2 weeks. All right, so let's start looking at the findings that we got. So the histopathological findings demonstrated a vacuole interface dermatitis. The underlying dermis exhibited a superficial perivascular lymphohistiocytic infiltrate with scattered melanophages and rare eosinophils consistent with a fixed drug eruption. So this is a medium power view that you're seeing on the slide here. And this next image shows a higher power view highlighting interface damage, squamatization of the basal layer, and necrotic keratinocytes. As for the other results, all blood work returned within normal limits except for the anti-SCL70 antibody, which the patient stated that she had never had before. So that was kind of interesting. Again, to emphasize the onset of symptoms, the patient was started on etanercept in January of 2021. She received her first dose of the Pfizer-BioNTech vaccine in April and had the onset of a pruritic rash on her anterior neck and chest 1 week post-vaccination. In May, she received her second dose, and 24 hours later, a pruritic rash appeared in the same location, but with greater severity, and it continued to progress. So what was the outcome of this case? Well, at her follow-up in 2 weeks, her rash had completely resolved, and she was further being worked up by her rheumatologist. So let's dive into the discussion here. So in a previous report, cutaneous reactions to Pfizer-BioNTech and Moderna mRNA vaccines were described in a study of 414 patients. 83% of patients who received Moderna had at least one cutaneous reaction, compared to 17% of patients who had received Pfizer in this study. So a pretty big difference in the amount of cutaneous reactions between the two different vaccines. Cutaneous reactions to vaccination were described as frequently being mild and self-limited, and most commonly were observed as delayed local reactions. So local injection site reactions, including erythema, induration, tenderness, urticarial eruption, which would be describing wheals emerging away from the injection site, and morbilliform eruptions were occasionally seen. Less frequently, patients also could have displayed chilblains, face and lip edema, varicella-zoster virus reactivation, herpes simplex flares, or pityriasis rosea-like reactions. The report noted that most first dose reactions did not reappear after administration of the second dose. Currently, the literature is unclear if patients with cutaneous reactions from the first dose are more or less likely to also have an adverse reaction to the second dose. So I guess we'll stay tuned. A different study by Johnston et al. Described delayed cutaneous hypersensitivity reactions to the Moderna vaccine, including erythema, pruritus, induration, and tenderness around the vaccination site. In that study, 15 out of the 16 patients developed pruritic, variably painful, erythematous plaques at the vaccination site 2 to 12 days after the first inoculation. Lesions were described as benign and self-limited and demonstrated variable swelling and hardness with a few annular plaques. Cutaneous lesions after the second dose tended to have a quicker onset of 0 to 5 days and were similar to lesions after the first dose. Histologic evaluation in this study indicated a dermal hypersensitivity reaction after the second vaccination, with infiltrates of lymphocytes and eosinophils, predominantly perivascular and focally in the interstitium. In 2021, the New England Journal of Medicine conducted a study of the efficacy and safety of the Moderna vaccine in over 30,000 volunteers. Their results showed that delayed injection site reactions were noted in 0.8% of participants after the first dose and only 0.2% of participants after the second dose. So, not very frequent, and although these delayed hypersensitivity reactions occur, they are not occurring frequently enough to warrant not getting vaccinated. So the case reported in today's presentation aligns with current literature in regarding the timing of onset of lesions after COVID-19 vaccination. The patient had a pruritic rash that was similar to previously described lesions for COVID-19 vaccination, but it was novel in the sense that the lesions were not limited to the site of injection and appeared on the anterior neck and upper chest after both doses of the vaccine. As the patient was on etanercept for treatment of rheumatoid arthritis, it was important to determine if the lesions were caused by a drug reaction rather than to vaccination. The onset of adverse drug reactions frequently occur within the first few weeks of a new therapy and rarely occur after more than 1 month of use. The patient in the current case was on etanercept continuously for approximately 3 months before displaying symptoms, making it unlikely to be related to the medication. It cannot be excluded that the patient's symptoms could be attributed to etanercept, but based on the close relationship between vaccine administration time and onset of symptoms, unusual rash placement, and severity of lesions suggests association with the Pfizer-BioNTech COVID-19 vaccine. In addition, the rash completely resolved with corticosteroid treatment without halting TNF-alpha therapy, providing further support that the lesions were not due to an etanercept drug reaction. At this time, there is little information reported on adverse reactions to COVID-19 vaccination in patients with autoimmune disorders like rheumatoid arthritis. Clinical trials for the Pfizer-BioNTech and Moderna vaccines included patients with rheumatic disease in later stages of clinical trials, but did not include patients on immunosuppressive agents. Therefore, this patient's cutaneous response to vaccination is novel. There is concern that COVID-19 vaccines may incite rheumatic disease flares, but there is insufficient data at this time, and this patient did not show signs of disease exacerbation. Patients with a history of rheumatoid arthritis, a chronic systemic autoimmune disease, are at higher risk for more severe clinical illness after COVID-19 infection. The immunosuppressive properties of etanercept may also elevate risks associated with COVID-19 infection. These factors bring attention to the importance of COVID-19 vaccination to reduce the risk of clinical illness in patients with rheumatoid arthritis taking immunosuppressive therapeutics. It should be noted that cutaneous reactions are not a contraindication to revaccination, unlike anaphylaxis or other immediate hypersensitivity reactions. Although the adverse effects of COVID-19 vaccination in patients with autoimmune conditions are not well characterized, the potential benefits from vaccination heavily outweigh the risks. In conclusion, I just wanted to go over some of the main points of today's presentation. Cutaneous reactions to Pfizer and Moderna vaccination were frequently mild and self-limited and most commonly observed as delayed local reactions, including local injection site reactions, urticarial eruption, and morbilliform eruptions were occasionally seen. And the report noted that most first dose reactions did not reappear after administration of the second dose. But currently, the literature is unclear if patients with cutaneous reactions from the first dose are more or less likely to also have an adverse reaction to the second dose. It should be noted that cutaneous reactions are not a contraindication to revaccination, unlike anaphylaxis or other immediate hypersensitivity reactions. Although the adverse effects of COVID-19 vaccination in patients with autoimmune conditions are not well characterized, the potential benefits from vaccination heavily outweigh the risks. Thank you for your time and attention today. If you have any questions, please contact me at the email address listed on the slide. Thank you.